Thank you all for having assembled at this hall for the keynote address. I would like to first invite the dignitaries, Dr. Jaideep Chowdhury, the chairperson of Growth, Development and Behavioral Subchapter of IIP, Dr. Sunil Godbole, the secretary of Growth, Development and Behavioral Subchapter of IIP, Dr. Sunil Godbole. And I'd also like to request Dr. Sudhakar Prasanna, the organizing chairperson of this conference, GDBPCON, to kindly occupy the stage. I'd request Dr. Professor and teachers of teachers, Dr. MKC Nair, to kindly come onto the stage and it's a warm welcome. Keynote address is something that we have introduced in this conference of GDBPCON, mainly to honor the founding chairperson of this chapter, Dr. MKC Nair. I'd like Dr. Sudhakar Prasanna to kindly say a few words to introduce the professor to all of us. Of course, he does not require any introduction, but tradition needs that. Dr. Sudhakar.
Good morning, everyone. It's a great honor to introduce Dr. MKC Nair, the teacher of teachers. Dear MKC Nair, sir, the Dean of Developmental Pediatrics. It is with an immense pride and admiration that we commend and honor you from the Growth, Development and Behavior chapter, along with IAP Tamil Nadu State Chapter and Chennai City Branch on this day. Dr. MKC Nair's impressive academic journey, culminating in an MD Pediatrics, a PhD in Development Neurology, an MBA, and Director of Science, Doctorate in Science, it speaks volume about his commitment to excellence. His profound knowledge and proficiency in these fields have not only shaped the future of healthcare, but have also enriched the lives of countless individuals, especially children. Throughout his career, he has held esteemed positions. Sir is currently the Professor Emeritus in Developmental, Behavior and Adolescent Pediatrics in Child Development Center, Trivandrum, and he is the former Director as well as founder of Child Development Center, Trivandrum, as well as former Vice Chancellor of Kerala University of Health Sciences. He was the National President of Indian Academy of Pediatrics in the year 2004, where he conducted the National Conference in Chennai, and in the same place. He was the lead, the Indian Clinical Epidemiologic Network in 2005 and 7, and he was the President National Neonatology Forum 2011 and 12, and various other posts. It's innumerable things, so I cannot enlist. And sir, his contribution to the IAP, where he served as the National President in 2004, is instrumental in advancing pediatric healthcare in India. As a founder director of the CDC, Trivandrum, he has played a pivotal role in establishing it as an autonomous center of excellence in early child care and education, adolescent care and education, premarital counseling, women's welfare, and related fields. His guidance and leadership have been invaluable in shaping the center's success. He is not only a shining star, but a guiding light in the field of developmental pediatrics. I thank the GDB chapter for giving the opportunity to introduce as a teacher for me also and teacher for many of us. Thank you, GDB chapter. Now I invite our Dr. MKC Nair to deliver his keynote address.
So good morning. The first Growth and Development chapter meeting, we had 11 people. In Calcutta, Dr. Dilip Mukherjee brought food from home. That was, I was the founder secretary, Sir was the founder president. It was like a family function because there's no money, nobody was interested in that, all that. But I must thank the pediatricians for finishing off their pediatric population completely by immunization, ORS, and all other methods that made them now jobless actually. And that has made pediatricians think that developmental pediatrics and adolescent pediatrics, apart from of course critical care, actually these are the three selling pure pediatric subspecialties whereas other things are there, of course. Why I'm saying this is because it is the bread and butter of pediatricians now to learn developmental pediatrics, because parents are so much aware of it now. That was not the case when we started 40 years ago. So all my respect to Dr. Dilip Mukherjee. Probably, to best of my knowledge, he is the first person to do PhD in growth assessment, and maybe I am the first person to do PhD in developmental assessment. Now, what I am going to tell you in the next few minutes is the lessons learned in the last 36 years. 1987, the Child Development Center started as a project, and now with a 50,000 plus 50,000, 1 lakh rupees, that's all. No support for next 4-5 years. I had to pay the staff from my own pocket. Then 95 government took over. After that we didn't have much problem, financial problem. And now it is worth about 100 crores. Okay? So everything starts from nothing. I think that is what I want to tell the youngsters. Just because nothing happens tomorrow, day after tomorrow, don't be upset. If you are determined, if you have the vision to do something, it will happen, if not today, tomorrow. Okay. So if I tell the story in a little way, 1987 the project started. 91 we had the first Trivandrum development screening chart validated and published. 92 we had the CDC model early stimulation, a randomized controlled trial showing that it is effective came. 95 the first PG diploma in clinical child development course started. 2004 the development neurology course by Kerala, and plenty of you have done it. At least thousands of you have done the course every year from 1990 to 2004. 2005 we had a child development referral unit. Now it is called district early intervention centers. 2009 we had 7 screening tools and home-based intervention package. Mark my word, home-based intervention package. In the whole child development or disability, if mother is not a partner, none of your work is going to work out. Okay? Because mother is the only person in this world interested in the child. Of course, to some extent father. Not all fathers, but quite a few of them now. So not a therapist, not a doctor. Our interest is 30 minutes, 40 minutes, 60 minutes. After that we have no interest in the child. Then you have 2011 we started ultrasonology genetic metabolic because that was important to diagnose before the birth. 2015 it became a center of excellence by Government of Kerala, and it works only with this, I think. Is it? Okay. Now there are few lessons I would like to say. Just count these lessons. Number 1, a life cycle approach to child adolescent development. Now if you look at 2025, it is the 50th anniversary of ICDS. It's the first time WHO has recognized ICDS as one of the 7 major child development projects in the world. Okay? And 2025, I think all pediatrician development chapters should be preparing for celebrating it. It's not a small thing. ICDS has made sure that the poorest of poor child anywhere in the world, particularly in India, get the opportunity to become smart, speak well. You go to an Anganwadi, the child will be, you tell them to sing, he will sing, or she will sing. Tell them to talk something, they talk so confidently. We created a generation of confident children, and that is important. And of course, it had major programs of pregnant women, children, adolescents, caring for the critical 1000 days, and then you have the preschool years. We'll talk about it again. Now, second point you need to remember, the first 1,000 days, what UNICEF is proposing and UNICEF is so much promoting, but the roots of it has been there long ago. But the point is, an individual talk about it, it doesn't get accepted. Whereas an international, organization, particularly a UN organization, talk about it, it has high value. And I must say, compared to any other international organization, UNICEF somehow has a positive image across the world as the champions of children. So that is a great thing. What is this 1,000 days? 270 inside the tummy, 365 plus 365. So 1,000 days. Because this is the time your neuronal connections increase billion-fold. That's the point. Okay. Now, we need pre-conception. Third point important is premarital or pre-conception. A huge module is coming. We are finalizing it now, President's Action Plan. And two things I want to talk about it. One, perinatal folic acid. So what is so new about it? We all do it, you will say. We all do it, but we don't do it properly. All the obstetricians give folic acid after 24 days. Never before. Reason being, you get pregnancy occurs between 2 cycles. That means for around 14th day, 14 plus the girl will wait 1 week, 21, another 2-3 days before you reach the gynecologist. So that won't work. The moment you decide for marriage, you have to start folic acid. That is most important. Okay. In fact, my MD thesis in 97-99 was congenital anomalies. Same time, Dr. I.C. Verma also published the largest number of neural tube defects. But that time we didn't know that it can be prevented by folic acid, but we know now 73% of neural tube defects can be prevented. Now, some of the papers that we have described are epoch-making new discoveries. Some of them are so simple, but if you do for millions of people, the ultimate result will be 100 times or million times more. You get the message I'm saying? This is an intervention which will save a lot. Second, of course, rubella vaccination. And I am proud to say that even the best, immunization expert was opposing it. Even then, for the last 30 years, I have persisted with the idea that rubella vaccine is important, and now every child, class 9 child is getting it, free of cost. At least in Kerala, I'm sure must be there in Tamil Nadu also. I'm sure. Tamil Nadu is always one step ahead. Okay? So what does it mean? It means that you can prevent. Why did I insist on it so much? Because there is a book called Vaccinating Against Brain Syndromes. What did that book say? That the moment this was what is called rubella vaccination was introduced, the fall is like, rubella syndrome fall is like this, sharp fall. Not only that, many neurological diseases which we never thought was related to rubella also disappeared from the scene. That is data. So you must believe the data more than the expert. You get the message? So I said, I don't care what other people say, but the data, unless you disprove the data, is wrong. And whatever bad you may say about Americans, they don't do fudging data. Their data is definitely reliable. So why not we accept it? Okay. Next one. The third point is, we should do a simple developmental assessment for billions of mothers should become a developmental expert. And they don't have to do any intricacies. They only have to do 4 things. Okay? At discharge, I will talk about it later. 2 months social smile, 4 months head holding, 8 months sitting, 12 months standing. Last 25 years or 30 years, more than 30 years, I have been giving this card to about 15 to 20,000 deliveries in the SAT hospital, invariably the mother will come at 4 months saying that there is no head only. What a better method than this? You know, here we discuss in academic meeting about that tool, what is the sensitivity of that tool, what is the predictive value, what is of this, compare which tool is better, go to hell. None of these are important. What is important is, whatever little we do, it should reach to any what do you call, mother. One of the biggest epoch-making thing has been done by your former Chief Minister, M.G. Ramendran sir. Politically you may be for or against, I am not bothered about it. But he gave what is called midday meal program. There is no intervention in the world that is better than that. And now whole of India is doing it. Because he knew the feeling of hunger. Get the point? So such interventions are required. Then make sure the baby see, hear and listen. 32 years ago, when I made it, somebody said, why you write only see and hear? Why listen? I don't know why I did it. Actually, I don't know. But now I know it is important because earliest marker of autism. Somewhere in the subconscious mind, I might have had that. If you play with a baby, either baby should smile with you or cry. He is allowed to do both. If you don't do anything, don't respond to you at all, then it could be the earliest marker of autism. And first, of course, ultrasound head and OAE examination. As NNF president in 11, I think, 1911, 13, it has made mandatory that if you have an NICU, that's the first time we made it mandatory that if you have NICU, you should have neurodevelopment follow-up, and most important, you should have ultrasound. And if you look at it, anybody can find out. See, look at the periventricular damage. If you have any periventricular damage, you know this baby is going to become cerebral diplegia. Why wait for 6 months, 1 year? Start the early stimulation then only. Next point is probably my major contribution in life. The first time proving that early stimulation is effective. Above 2500 gram have something called 84. It's not exactly IQ, something like IQ. It's a Bailey index, 84. The below 1500 gram has 75. Okay? And if you give early stimulation, that 75 become 83.8, which is same as 84. So the damage because of low birth weight can be compensated by early stimulation. And what is early stimulation? All that your grandmother used to do. It doesn't cost anything. You spend time with the baby. Father, mother, grandparents take. You know, think of our younger days. Last week my sister was telling me, I only brought you up. It's true. She is much elder to me. So after some time my grandchild called, is that your mother? I said, no. Sister, but she is like my mother. She was very old, elderly sister. You understand my point? So many people, the child is not allowed to be on the ground. Whereas now, you put there, give the video, mobile, and the child is on his own or her own. Okay? And of course, we had the IAP. 2004, when I was the national president, and this hall is very precious to me because it is in this hall that I took over as a national president. The in-between partition was not there. In-between partition was not there. It was a huge hall. And the governor of Tamil Nadu who was a Andhra Pradesh IP, DGP something, who was the chief guest. Okay. Now, if you look at this one, this is one slide you must take home. You want to take a shot of it, you take it. No copyright. It's a most important slide. What does it say? For last 70 years, we have been doing disability surveys. And every time you do disability survey, the same fellow will be caught. If I walk like this, I am motor problem. If I don't see, do like this, I am this one. If I don't hear then you become this thing. This is the way we were doing disability survey. Obvious ones we are picking up. And what can you do with the obvious one? Very, very little. Just the slide is little turned up. It should have been down. Below 6 years should have been here. Okay? And look at, instead of that, we focus on developmental delay, communication delay, focus on language delay, motor delay. All sort of delay you look at, what happens? The results will be near 100%. And the biggest mistake that happens here, not a single child get diagnosed as autism early. They all go to speech delay, go to speech therapists. Poor thing, they can only practice what they have been taught. They are expert people. I have no complaint with them. They are experts in their subject. But they have been taught to do speech therapy. They will do speech therapy. Then suppose it go to psychologist, they will say he has hyperactive. Then it goes to another person, he will say it's a behavior problem. Then it will go to ophthalmologist, say that he has problem with the eyes. But the whole total is autism spectrum disorder. We don't diagnose it because we are obsessed with the idea that's of speech. The problem an autistic child has is not speech at all. It is communication delay. Child is not able to communicate. Haven't you seen people who can communicate so well but no speech at all? They can communicate so well but no speech at all. Second, socialization delay. They cannot mix with people, they cannot recognize people. Then of course, emotional delay we call it. They can't understand the emotion of other people. These are the three problems of an autistic child, not speech delay. Okay? So, and then of course you have 10 neurodevelopmental disabilities, including global delay. Including global delay. Global delay again is important. Do not diagnose global delay because when you do a test, 3-4 areas have delay. Make it global delay. No. Global delay is not more than one area delay. Global delay definition is more than one area affected but significant cognitive delay. He is the younger brother of IDD, intellectual disability. So unless there is an obvious cognitive, this I am saying for postgraduates. The moment you find 3 or 4 areas delay, more than one area delay, global delay. Global delay is invariably poor prognosis. Don't tell the mother diagnosis of global delay unless there is significant cognitive delay because tomorrow he is going to become IDD. Then I said about, don't look at all this. I will say the whole thing in one sentence. The whole of Kerala we did a study. One Anganwadi area, all children per panchayat and one municipality ward per municipality. And what we found is less than 3 years, 3% development delay. I can give you 10 or 12 studies show that it will vary from 2.5, 2.8, 3, 3.2 like that. Whatever it is, around 3%. Less than 3 years, 3% development delay. And out of this, see 70%, out of the one screen positive, 70% is development delay, 14-15% is speech and language. So the two things that you should know is speech and language delay and development delay. Because both will give results. I will show you the results of that. So next point we need to look at is the word called habilitation. Okay? What is habilitation? We have been talking about rehabilitation from day one. No, that is not what pediatricians should talk about. Rehabilitation is the forte of, other specialists, therapists, all lot of. We may do it, but that is not our primary responsibility. Our primary responsibility is habilitation, which means prevention of impairment going on to disability. That is what you are here for. And this is exactly what is it for developmental therapies. The role of, because there is a whole huge discussion coming at national level, what is the role of developmental therapists? Development therapist is a person And Ramendra, we have a very good unit, I know. Karthikeyan Center, I think, no? Isn't it? Karthikeyan Center, I had come to inaugurate it. My two girls were here. It was beautifully done. The way we do follow-up. Nobody else is competent to do follow-up of small babies because they should know neonatology, they should know early childhood. All the therapists are highly qualified, trained people, no doubt about it. But their training is mostly in adult. Even if you are a pediatric therapist, specially trained masters, then also you don't see so much of newborn. Whereas the pediatricians and development therapists see that. So up to 2 years, even if they may do up to 6, but say that up to 2 years, it is a photo. That is called it's the first book in the world, I believe, on development therapy just published. And of course, this is of course Illingworth, where Dr. Naveen also has contributed a lot. Okay. Now, the largest study in the world, well-conducted study, quoted across the world, is the England study on early neurodevelopmental disabilities, 10 neurodevelopment. Why I say it is good? Not because I did it, because this is the first time we never believed in a screening test, and if screening test is positive, it becomes, you do a diagnostic. You understand? Then what happens? There is false positive, false negative. Here, 4,000 sample have been collected from 4 parts of India, not a child with problem. It's a children playing around in the community between 2 and 9 by population proportion sampling, PPS method, and then 10 diagnostic tests was given to all the children. No screening. There is a screening tool, but we didn't go by that. So what happened? 40,000 into 10 means 4,000 to 10 means 40,000 tests. Into 2 hours for one test means 80,000 hours at least minimum has been used. And because the child may not cooperate things, then it becomes even more. And what is the result? Don't look at all this. Don't bother about any of these details. Less than 10 years, you have 10% neurodevelopment disability. Little difficult to believe, I know. Out of 100, how can it be 10? You look at the hearing problem, look at the vision, then you will agree with it. Because the moment disability means we are talking about cerebral palsy, we are talking about obvious things. Okay? This is the most reliable data. Okay. And that is why we have this RBSK. RBSK, 3 of us sat down in Calcutta, I must say credit to Calcutta, where we decided on development delay, defects delay. In fact, even defects we didn't add. Delay and disability. But the government of India added 2 more D. What is the 2 more D? 2 more D? Deficiency. And 1 more D we are planning to add. The moment there is a consensus statement coming on habilitation, in that one discernible risk. Discernible D means the one even before the risk is not obvious. Discernible risk. 5th D is going to come. Next. So, what is rehabilitation? Prevention of disability going on to handicap. Team approach a must. Nobody, all of us are good. Together we are good. Individually we are not perfect. Are we? Can anybody sitting here say, I am the perfect person? Is it possible? No. All the therapists should get together under the leadership of a developmental pediatrician, then the team is good. But we don't have that team approach so far. In this book, what I am trying to say is that all the therapy, and by the way, please read about this therapy, because we as pediatricians are not taught anything about therapy. That is why the therapists think anyway these people don't know anything. Why bother to talk to them? You understand? Have you seen that action? For many, I am 100%, I love the therapists, I have no problem. But I am saying, because we don't try to learn at all. We must learn therapy. This book, all the main therapy have been written by me after 1 year literature search. So that whatever is said is as per literature. This of course everybody knows, like TDSE you can have the language evaluation scale. Now speech therapists are all using it. Why they are using it? Instead of going for reels which is time consuming, they can do it quickly. Now they are also quietly agreeing to it. Pediatrician never used this. You know that joke? Pediatrician were not using the TDSE at all till I told them a trick. What is it? In your table you have a blue cloth, the glass and all that. Underneath you keep these two, TDSE and less. When the mother asks, my child is this old, is it normal? He is not doing this. Is it normal? Can any of you remember? I can't remember. Can we remember all this? So what do? You put your hand like this, look give an intellectual look, just look into the sheet and say, yes, this thing. Are you sure, sir? Yes, I am 100% sure. Who is sure? The chart is sure, not you. But then chart is what? You go to somebody else, he will also do the same thing. After some time, parents will think that why these people are, thinking like this. But that has made the tool more popular. Quickly we can identify. Okay. Sorry, one more. And what does it say? Early language stimulation. Early language stimulation is not speech therapy. Speech therapy is a professional job where there is speech, but there is lot of problems. Soda error we call it. Substitution, omission, all that. Okay, deletion, addition, soda error. That's only, we should not touch it because we know nothing about it. It's only the speech therapist should do. But early language intervention, the best early language intervention is who? The mother or the grandmother. He will sit with the baby, he will say, ah, he will say, ah. Then you keep on repeating what the baby say, he learn language. And only school for early language intervention is Anganwadi. Why? Because in Anganwadi, what is no restriction on the child. Normally when the child come to school, they want to tell the stories that they saw. Keep quiet, sit straight, only after the prayer. Whereas in Anganwadi, you have no restriction. The first thing children will comment is, teacher's sari is very good, very good. And suppose the sari is not good, they will say the sari is not good. Because they are only talking about things that is around them. They are not talking big things. But that curiosity makes them start talking. They play with children, okay? Because they shout, that speech will come. This is the important thing, okay? Next, one more simple thing. I don't know how many of you use Habilitation angles. Please put your hand up. Habilitation angle, how many of you use? It's a wonderful thing. Because neurology is a tough topic. Yes or no? Is it a tough topic or not? No, maybe not for Srinivasan. Srinivasan has the distinction of going to PGI and talking about congenital heart diagnosis. Did you know that? I mean, I am not like him. That's all intellectual people who do all that. I am a simple person. I can't remember all this neurology. But I know how to separate the leg of the child and show that there is hypertonia. And if hypertonia remain for 1 year, it's a persistent hypertonia. Tomorrow he is going to go for CP. Is it difficult? Is it difficult? Not at all difficult. You see, why I say Srinivasan not for joke. All your senior teachers knew this basic stuff so well, which we don't know. Next generation don't know at all. They only know by what? MRI. You understood? That's not their fault. They have been taught like that. Whereas these people had no other choice, so clinical was there. Okay. Now what is the thing? If you don't do early stimulation, this is my hand, by the way. This is my hand. 40 years ago maybe this is. And what happened? This baby, put on early stimulation, he will not develop diplegia. Look at, otherwise by the time he's 6 years old, he has severe restriction. The muscles are wasted, joints are wasted, and you can't make the child walk. Okay? And what do you do for that? Typically, take the baby astride the hip. The mother can do every therapy. Can any of you show me how a baby to be carried? Can any of you show me how a baby to be carried? Madam, she is enjoying my talk maximum. Do you know how to carry the baby? Just show it like that. A CP child, how do you do therapy? What is the problem of CP? Like this. Crossing of legs, bending of knee, toe with the, up walking like this, back bending, hand like this. And what do? You take the baby, astride, automatically adductor spasm will go. And after delivery you have a tummy, paunch will be there. God has purposefully given it so that the baby's knee can be put on top of it and you can do boom, 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 play like this. Mother's tummy will make noise. Child enjoys it. And the foot, what do you do with the foot? The foot is like this. You keep on doing the therapy. Whereas, if you refer to physiotherapists, what will happen? They are trained to do stretching. They will stretch once, the baby will never go anywhere near. Does it mean that it's not required? No. There may be a 7-month-old baby with severe CP finding. Their stretching has to be done. But the 99% of newborn follow-up cases, you only need to play. In fact, when the babies come to me, as soon as see my face, they start laughing. Like a big joker. Because I make all funny faces, do all this, play with them. They don't know you are doing therapy, you are only doing that one. I think this is important. Then autism. There are umpteen number of methods that have been popular. Until recently, ABA therapy was very popular. If you want to go to Gulf, you get trained for that. But now it is proved that, and I have all the data, that is not so effective. So many things are not effective. For CP, NDT is not effective when you do a meta-analysis. Doesn't mean we won't do it, we still do it. But the point is, what has been proved effective is group therapy. I will show the result. And so many autism tools are there. So many. Including ISA. How many of you use ISA? Just put a hand up. How many? What is the problem with ISA? I was one of the members who finalized the ISA and accepted for Government of India. But the problem is, between 3 and 4 years, it is not at all good. And I pointed it out, usually, and then they said, sir, we spent so much money, we spent so many years, don't say negative, agree. I said, okay, no problem. Otherwise, it's okay. Up to 18, it's perfect, no problem. But first 2-3 years, it is not. But Government of India says to give the certificate, you want ISA, use it ISA. But what I use is Trivandrum Autism Behavior Checklist, which has been validated against CARS. And the first time the CARS won, the negative predictive value was 98%, which means we can say out of 100, 98 when you say it is not autism, it is not autism. Confirmed. And here, second one, CARS2 just published 97%. So difference may be in 2 or 3, which is acceptable out of 100. You get the point? Doesn't cost anything. You don't have to ask anybody for that. We have to remove, and that is why Vaman, I was appreciating so much of work that he has done. I don't think he is here, but I must say that he is a person who talk about Indian data. You remember the 4 or 5 centimeter difference he talked about Western data and our children? For which one? What condition? Forgot. Which condition he said? Turner. And for them, lot of Turners will be there. So we should have our data. It's a new India. Forget about old things. We tried using our own tools. Okay. Then of course, school entry. School entry, what happens? Because the child is 5 years old and because his father is a pediatrician, eminent pediatrician, your grandchild is sent to the best school. Because your father is a pediatrician doesn't mean your child has the capacity to do it. What happens? After 3 months, teacher will say this child is not doing anything, blah, blah, no pre-writing skill, no pre-reading skill, no skill. and then you come back. Then what happens? You say you are declare you as a failure. Mind you this word. Already he has been told that you are the worst among. In Hindi we call chuta, I think. No? Is it Hindi word, no? Chuta, or is it our word? Means the worst among it. Why put a label? That is why in the government of India, in the new policy, education policy, they have taken LKG, UKG, class 1 and 2 together. No exam, no promotion, nothing. Why? Because till 2 years, as Piaget said, till 7 or 8 years, you are still a child who understand only playway method, not the language that we are talking about. Got it? So what I say is, suppose the child is doing badly on this one. See, look at it, 72 months. Sorry, I made a wrong thing. I put the wrong one. Sorry. If it is 72 months or 73 months, up to 26 items he should do. 1 or 2 is okay. But suppose he doesn't do 5 or 6 items, you wait 1 more year. Nothing will happen. Child will go next year to school. But he will start as a good start. He will have a good start. Most important. Okay. Now this is just issues that we have a group called Global Group on Development Disabilities. Just the latest publication we had on promoting school readiness in children with developmental disabilities. Okay. I put this slide because same talk I had given to Global Forum and they wanted this slide to be there. Okay. This is we had a beautiful neurodevelopment pediatric update on 12, 13, 14 and all the big shots you can see. Arun Singh, who designed the RBSK, is there. Aurora is there. All the and the lady from GRDD representative, the lady from Jordan, she is there. We had a good meeting. Some of you might have attended. Okay. Nothing great about it. These are the 5 steering committee of the Global Research on Development Disability Collaborators. We are doing many publications and I represent India. Okay. So what are the 3 or 4 lessons I said? Life cycle approach, neurodevelopmental follow-up with a lot of focus on low birth weight babies, and you need to have all therapies, habilitation less than 2 years, and once there is a disability established, the rehabilitation below 3 years, 3% delay, below 10 years, 10% neurodevelopment disability, and all therapies should work together. Do not look down upon therapies. I am telling you, no pediatrician should not look down. We have learned 4.5 years, they are in MBBS or 5.5 years, they have learned 4 years. They are no less than us. But unfortunately, most of them may not have the experience of small babies. So with respect you approach them, try to learn from them, but before you go to them, also learn little bit on therapies. Thank you very much.
Our profound thanks to Professor Dr. MKC Nair for the illuminating keynote session.